Thank you, everyone. I hope you had a good lunch. I always love coming to Belgium, where they give you wine at lunchtime during a conference, but it probably doesn't do very much for the attention span in the immediate after-lunch period. But anyway, as you'll have seen, our first speaker is Caroline von Holsbeke, who is another key player in terms of IOTA and has done a huge amount of the work involved in certainly the earlier phases of IOTA, and that she's been involved subsequently IOTA 4, IOTA 5. We talked a little bit this morning about validation and how models that have been developed within the IOTA group perform, but Karen's going to talk about validating models both within and outside the IOTA group. So I'm going to hand over to her for the next half an hour. Thank you.
Thank you and good afternoon. When we are talking about validation of models, of course, we first have to develop the model. Then a model has to go through temporal validation. Then we go to external validation, and if the model proves to perform well even after external validation, you could try to implement the model in daily clinical practice. And this is what we have done during the IOTA studies by developing the IOTA models. And during my talk, we will focus on external validation of the IOTA models and strategies. But how can we use the IOTA models in daily practice? If I show you the formula of the ADNEX model and the formula of the LR2 model, then I think that we can all conclude that it's impossible to use it in daily clinical practice when we are scanning a patient. But thank God, now we have the apps, and now when we are scanning a patient, we can simply use the models, and you can choose between LR1, LR2, the simple rules, and the ADNEX model. But never forget that it's very important when you use one of the models that we all speak, like Lil told us this morning, we all speak the same language, that we know how to scan a mass and look for the required variables of the models, and that we had some training concerning the IOTA variables, and that we achieved our IOTA certificate. So have IOTA terminology and variables been validated? And there's a nice study done by Povilas and Lil concerning this subject. And in this study, 117 patients with an axial mass planned to undergo surgery all had an ultrasound scan performed by either one expert A or expert B. From all the patients, the ultrasound variables that are needed for LR1 and LR2 were described by using the IOTA terminology. And all the patients had surgery within 90 days. These are the histologies of the patients. 94 patients had a benign tumor, 4 had a borderline tumor, and 19 patients had an invasive malignancy. And Povilas helped me with understanding this table, but the conclusion is that inter-observer differences were not bigger when the mass was larger, that limits of agreement were wide but acceptable for all measurements, and that the least reliable measurement was the height of the largest papillary projection. This is the inter-observer agreement for categorical variables, which was a good agreement for most variables, but moderate agreement for regularity of the cyst wall, acoustic shadowing, vascularization in papillations, and the color score. This table shows us the inter-observer reproducibility when calculating the risk of malignancy by using LR1 and LR2 by the two experts. And the conclusion is that when classifying tumors as benign or malignant by using LR1 or LR2, the inter-observer agreement was good for both models. And here you see the inter-observer differences for both experts in relation to the risk of malignancy percentage when using LR1. And you see that there's a good agreement in the low risks and in the high risks. And the same is for LR2, a good agreement in the low risks and the high risks, high risk calculations by the model. So in 11 cases, there was more than 25% difference in the calculated risk, and this was due to a discrepancy between the examiners in one categorical variable in 4 cases, in 2 categorical variable in one case, and a discrepancy in 1 or 2 categorical variables, and a substantial difference in measurement in 6 out of the 11 cases. And the categorical variables where there was disagreement was color score, regularity of the cyst wall, flow in a population, and acoustic shadowing. The difference in the calculated risk was never explained by differences in measurements alone. So conclusion for this study is that the calculated risk must be similar to the actual risk, but also that the calculated risk for patient X must be reproducible by everyone and everywhere. So 2 experts agreed quite well in their classification using LR1 and LR2. Nevertheless, a difference in estimated risk of 25 percentage units was found in 9% and 12% of cases when using LR1 and LR2 respectively. And the inter-observer agreement was poorest for variables that contained some subjective evaluation like color score and acoustic shadowing. And this was also what they found in a similar study from the same group where they analyzed clips of 83 masses that were examined by 7 different examiners with different level of experience. And again, the conclusion was that inter-observer and intra-observer agreement was good, but that there was sometimes a discussion in defining whether a solid component had to be classified as a population as well. And you might understand that for some people this is only a solid component, and for other people this might be a solid component protruding from the cyst wall and has to be classified as population as well. So now let's go to the validation of the IOTA models, and the first external validation was published in 2011. The aim of this study was not only to externally validate our IOTA models, but also to compare the performance with old previously published mathematical models. And because we are talking about external validation, we didn't include the patients from the old centers that participated in IOTA phase 1, but only the patients of the new centers, which were 997 cases. From these 997 patients, 74% had a benign mass and 26% had a malignant mass. We tested 12 IOTA models, and we also tested 12 old models, of which 4 were a scoring system, 6 were logistic regression models, and 2 were artificial neural networks. And we examined the performance of all the models, not only by looking at benign versus malignant, but also by looking at benign versus stage 1 ovarian cancers. And these are the performances of all the models, and the area under the curve is ranked from high to low, first for the old models and the RMIs, and then for the IOTA models. The best old model was a logistic regression model by Timmerman with an area under the curve of 0.92. The best RMI was the one of Jacobs with an area under the curve of 0.91, and the best IOTA model was LR1 with an area under the curve of 0.95. And this was significantly better than the best old model. Also, when we looked at the area under the curve for benign versus stage 1, the highest area under the curves were achieved by the IOTA models. Here you see the performance in terms of sensitivity and specificity. And again, the highest sensitivity rates were achieved by the IOTA models. Also for sensitivity for benign versus stage 1 cancers. Here you see the types of malignancies that were missed by the 2 IOTA logistic regression models, LR1 and LR2, and by the RMI. And you see that the RMI missed 42% of the stage 1 cancers, compared to 3 and 5% by LR1 and LR2, that it missed 73% of the borderline cases compared to 17 and 21% by LR1 and LR2. And this is the performance for RMI versus LR1, and you see these are the benign cases that were missed by RMI and LR1, and you see that RMI missed more borderline tumors than LR1, missed more stage 1 cancers than LR1, missed more high advanced ovarian cancer, and missed more metastatic tumors. So we proved that subjective assessment works very well in the hands of experienced examiners, and we proved that the IOTA mathematical models work very well in the hands of experts and better than the RMI. But what about external validation of the IOTA models in less experienced hands? And I will show you 4 studies concerning external validation of one of the IOTA models or strategies. And the first one is a study from Nunes, published in 2013. And they looked, the patients were analyzed by level 2 operators, which are mainly doing the routine gynae scans and just describing the measurements and the morphological variables, and level 3 operators, which also are capable of discriminating between the benign and malignant character and even try to presume a specific histology. So 292 patients, of which 55% were malignant and 47% were postmenopausal, were scanned by a level 2 examiner, and he had to discriminate between benign and malignant by using LR1 and LR2 and his own subjective assessment, and they were all assessed by a level 3 examiner using his own subjective assessment. Here you see the performance of LR1, and you see that the area under the curve remains very high, 0.94, also in the current study, when compared to the IOTA original and external validation study. That sensitivity was even significantly better, and specificity was less than in the original studies. This is the same performance table for LR2, and again, a high area under the curve, a better sensitivity, and a less specificity for LR2. Here you see the performance of subjective assessment or pattern recognition when tested by experienced and less experienced examiners, and you see that the sensitivity was 87.5% for after external validation and 95.5% in the current study, which was better than the performance of LR1 and LR2. So in conclusion for this study, the performance of LR1 and LR2 is similar when used by experienced or less experienced ultrasound examiners in terms of area under the curve. However, in the hands of experts, the models are more sensitive and less specific. Maybe this is because expert examiners use also pattern recognition when looking for the variables that are needed to assess the performance of the LR models. This is another strategy that is developed by the IOTA group. It's a 3-step strategy, and I will first explain you how this strategy works. We start from all the patients, then we rule out the easy cases that everyone can discriminate as benign or malignant. That remains us with the more difficult cases. On these we apply the simple rules, and the cases that are conclusive can be discriminated as benign or malignant as well. And on the inconclusive group, we assess LR1, LR2, RMI, or subjective assessment. So the first step are the easy cases or the easy descriptors. For example, a unilocular mass with ground glass echogenicity in a premenopausal patient is always an endometrioma. A unilocular mass with mixed echogenicity, acoustic shadowing in a premenopausal patient is always a teratoma. A unilocular anechoic cyst with a regular wall less than 10 centimeters should be a simple cyst or cystadenoma. And also a unilocular cyst with regular walls and a remaining echogenicity should be a simple cyst or a cystadenoma. But if you have a color score of 3 or 4 in your mass and the patient is postmenopausal, she's malignant. And if the patient is more than 50 years old and CA1 to 5 is higher than 100 units, the patient has a malignant mass as well. In the second step, you can use the simple rules, but the mass can only be classified if only the benign or the malignant rules are applicable to the mass. These are the rules to predict a malignant tumor, and these are the rules to predict a benign tumor. And as a third step, we can use LR1 or LR2, or we can use RMI. So let's do it as we said. We start from all the patients, which were almost 2,000 cases. We rule out the easy cases, which were 902 patients. This means that 50% of all the masses can be easily classified, reaching a sensitivity of 97% and a specificity of 98% in this group. We continue by using the simple rules, and they were conclusive in 661 cases, of which 26% were malignant, and they were inconclusive in 375 cases with a slightly higher malignancy rate. Another 30% of the masses can be simply classified, reaching a sensitivity of 89% and a specificity of 91% in this group. And as a third step, We used LR1, LR2, RMI, and subjective assessment. And when we compared the three-step strategy, we found out, and compared it with subjective assessment by an expert examiner, we found out that subjective assessment as a third step here gave us the best performance and was similar to subjective assessment alone. We had a sensitivity of 92% and a specificity of 91% for the three-step strategy and a similar performance by subjective assessment alone, and this was less for the RMI alone. This three-step strategy was also externally validated and compared with the RMI. It was tested after real-time examination by level 2 sonographers, so no level 3 sonographers who all had the IOTA certificate. So again, we start from all the masses, the easy cases, the simple rules, and then finally subjective assessment, but by a less experienced examiner. And the study was done in 301 patients, of which 62% were premenopausal and had a malignancy rate of 31%. So the easy cases were 46% of all the masses, could be easily classified with a sensitivity of 93% and a specificity of 97%, which was similar as the use of RMI in this easy case group. The simple rules were then applied and were conclusive in 131 cases. So after 2 steps, almost 90% of all the masses could be either easily or simply classified. And the performance after 2 steps gave us a sensitivity of 95% and specificity of 95%. And for the RMI, sensitivity dropped to 73% and specificity was 95%. And as a third step, we used subjective assessment. And then we had a performance of 93% and 92% for specificity. And for RMI, it was 72% and 95%. So conclusion for external validation of the three-step strategy is that it showed the same performance as in the original study, even with a level 2 or less experienced examiner in the third step instead of an expert. However, step 3 only included 11% of the whole population instead of the 36% in the original study. So we would advise that referral of the step 3 patients to an experienced examiner is probably the safest strategy. And in this study of Ahmad, he externally validated not only IOTA models, but also simple rules versus the RMI. In 3 UK hospitals, patients were scanned by less experienced examiners, who all had their IOTA certificates, and they also looked at the relevance of operator experience in number of years of gynae scanning, number of gynae scans performed, number of ovarian masses examined, and background training. And we tested LR2, RMI, and the simple rules in this study. What if the simple rules were inconclusive? Then all the inconclusive masses could be either classified as malignant or they could be classified as benign or malignant by subjective assessment. And they also developed a regression model using the number of ovarian masses scans performed, and they also looked at the background training, which was doctor versus sonographer. So 255 patients were examined by 35 examiners, of which 65% were premenopausal, and the malignancy rate was 29%. And here you see the performance with the best performers for LR2 with an area under the curve of 0.94, and the RMI was worse with an area under the curve of 0.9. Here you see the performance for simple rules versus RMI, and you see that 84% could be classified by the simple rules and 60% were inconclusive. So now you see the performance. RMI only achieved a sensitivity of 72%, and there was a good performance for simple rules with malignancy as second step or with subjective assessment as second step. Specificity was significantly less than for the RMI and was similar when simple rules and subjective assessment was used. Here you see the performance in the premenopausal patients with a very poor sensitivity for RMI and a similar performance when LR2 was compared with simple rules. And here you see the plots of the odds ratio to see whether there's a difference between doctors and sonographers. And you see that the doctors were better in using subjective assessment, that there was a similar performance when using simple rules or LR2, and that the sonographers were slightly better in using the RMI. Here you see the difference between less and high experienced examiners, and you see that when experts use LR2, they achieve a higher sensitivity and a less specificity, and that the RMI performed worse. So IOTA LR2 model and the simple rules perform well in the hands of examiners with different background training or relatively little experience using ultrasonography. And then the final study I want to show to you is one of Nunes. In the first part of the study, they validated IOTA models by scanning 303 patients by level 2 sonographers. And in the second step of the study, they did a Medline and Cochrane search to look at all kinds of studies that validated the simple rules. These were 237 patients, of which 55% were benign. Performance of the simple rules was applicable in 78% of the cases, and they achieved again a high sensitivity and specificity compared to subjective assessment. And when performing a two-step strategy using simple rules and malignant or using simple rules and subjective assessment, we again had a high sensitivity of 94 and 97%. These are all the studies that were included for the meta-analysis, looking at the accuracy of simple rules. And here you see that they had an overall sensitivity of 0.92 for the simple rules. So in conclusion, the performance of the IOTA models, simple rules, and the three-step strategy work well in the hands of less experienced examiners. However, the models and the apps can't do all the work. Using the same language and way of scanning an Excel mask remains the first step of any strategy. So try to get your IOTA certificate. Thank you.
Caroline, thank you very much. Question? I think the microphone should be. Who's got the microphones? Could the microphone just go over there, please? Who's? Come on. You're going downhill. You can go really fast. Keep going. There you go. Thank you.
I just wondered how many scans it takes for a level 2 operator to be a level 3 operator. In the study, which describes 290 scans, of which 50% of them were malignant, which then compared a less experienced versus an experienced operator, in the course of scanning, doesn't the level 2 slowly transform into a level 3?
Well, if I understand your question correct, it was not that they started from scan 0. They already were level 2 sonographers, so they already had done some scanning. And I think this remains a very difficult point. When is someone a level 2 scanner and when is someone a level 3 scanner? Because I don't know whether you saw it, but in one of the studies, the subjective assessment of a level 2 and an expert was quite the same. So when is someone really level 2 and when is someone really level 3? I think it's very difficult. And of course, someone has more talent, so it can achieve a higher performance after performing 1,000 scans, and another one may be needing 3,000 scans. It all differs also the type of masses that you see during these 1,000 scans. So that remains a difficult point.
Yeah, I mean, the levels in European terms is based on the kind of whether they're an expert referral scan and not on the number of scans that are done. It doesn't work that way. But it's a constant feature as to how, you know, similarly there was a paper when Joseph Yazbek did his paper talking about supposedly randomizing patients to being scans by sonographer versus supposedly higher level ultrasound, but it wasn't really about that. It was that people were more likely to make a decision if it was done by a consultant colleague than a sonographer. It wasn't about the level or the competency of the ultrasound in reality. The other thing about this study was that a number of the scans were carried out by sonographers who have, if you like, a slightly different training in the sense that they're asked to report features and not asked to make a diagnosis and advise on management. So, you have very experienced sonographers who are supposedly not as competent as some doctors, and that's just not true. It's just a question of how they're asked to report, and I think that training ought to change probably. I mean, Ben, wake up. I'm interested in this issue about inter-observer variation of individual variables between models and how that actually impacts on model performance. Do you have anything to say about that? Because it seems to me, I remember Laura was doing some work on looking at the variation of variables within centres, but how that does or does not actually impact on overall model performance, and that seems to be the case a bit. Am I got that right?
Well, this is a difficult topic.
That's why I asked you. Yeah.
Yes, I know. Thank you. Well, if you have a study with multiple operators and there is inter-observer variability, then the overall performance will probably be affected by that, I can imagine. But the other question I have is whether it is such a big deal if different people have some variation in the measurements they have. If, for example, the performance of one operator is good and the performance of the other operator is also good, is it a big difference if there is inter-observer variability? And this means that you will have different risks for the same patient when scanned by operator A or operator B. But overall, the performance of the model in the hands of operator A might be as good as the overall performance of the model in the hands of operator B. So then I think this is an issue of ongoing research in methodological work on prediction models. But the question is, what's bad and what's good? If the model works good in the hands of every operator, is that sufficient? Or do we really need to have variables that have no inter-observer variability? I don't think there is an answer for this yet. I think people expect that different people will arrive at the same risk for the same patient. But yeah, I can understand that people expect this.
Yeah, but you can have a different risk, but you'll come to the same management decision. That's the point.
On average, you may say.
You know what I mean?
Maybe
that's
not
what
for
will happen.
the same patient.
Okay, any other, thank you, Ben, that's very helpful. Any other questions? Did you put your hand up? Or were you just scratching your head? No? Okay. Okay, sold to the gentleman there. I think that's done. Karen, thank you very much indeed for that.